to the first of our 12-session treatment series interactive webinar that is being sponsored by the Bureau of Justice Assistance Drug Court Technical Assistance Project at American University. I want to welcome you to the session and thank you so much to David Mee-Lee, who will be the presenter. This session is going to address what to expect from state-of-the-art addiction treatment for criminal justice populations in applying the new ASAM criteria. We've organized the sessions for these series in a little different from the way we've done it in the past. Most of the 12 sessions will be two segments, where we'll have the first segment, like today, spanning about 45 minutes to address the key principles and issues, and 15 minutes for questions and answers, and then a follow-up session, which will be, in this case, tomorrow, to address additional questions that you may have. So we encourage you to send in your questions through the Q&A line on the website, as well as follow up. You will get an evaluation form after the session and indicate any other questions you have, and then we'll try to address those tomorrow. And you do need a separate registration to register for the session tomorrow, which was in the original, the email that was sent out for this registration. If you need it, if you don't have it, just let us know. I just want to thank everybody for joining. We have a great array of people. We have over 250 people participating, judges, treatment providers, probation officers, a whole array of treatment and court personnel. We have people from 46 states and Alberta, Nova Scotia, and Ontario, Canada. So I wanted to thank everyone for participating. I also wanted to mention that our series is with David Mee-Lee is going to be, I think, about 9 specific topics, and then interspersed with that 3 additional sessions that will address applications, case studies, clinical case studies that illustrate the principles that are being addressed. So in addition to sending questions, we hope that you will send some challenging cases in that we can then discuss in these different segments. And if we can do that through the Q&A, we will, but we wanted to have some challenging cases that you all are encountering that we can get the benefit of Dr. Mee-Lee and others' sessions. So without anything further, I'm going to turn it over to Dr. Mee-Lee. Thank you.
All right. Thank you very much. Thank you, Caroline. Just to let people know about who I am, and I appreciate the opportunity of doing this, I am a board-certified psychiatrist and certified by the American Board of Addiction Medicine, so that have been involved in my career in both mental health and addiction treatment. And in the context of this, I am the chief editor of the ASAM Criteria, so have been with the ASAM Criteria since its beginning, of the first edition being published in 1991, and the latest and current edition in 2013. Some of the work I do is with the Change Companies, and I'm based in Davis, California. Just to give you the context of ASAM, which is the American Society of Addiction Medicine, pronounced ASAM, not ASAM. Some people think it's a pain in the ASAM, but ASAM is an organization of about 3,000 plus physicians who are interested in helping with addiction treatment. And as founded, as you can see, in 1954, but now currently called the American Society of Addiction Medicine. And for your information, if you're not a physician, you can be an associate member. So if you are wanting to be more involved with ASAM, there is a way, even if you're not a physician. I wanted to start off, though, with just getting on the same page about what is addiction, and addiction as a brain disease, because you hear a lot about this, but there are implications of thinking about it as a brain disease. This is really, we're not going to get too technical with you, but you've probably all seen these pictures before of the brain reward system involving the ventral tegmental area and the nucleus accumbens and the frontal cortex, and this reward system where if somebody takes methamphetamine, you can see from the neurotransmitter of dopamine that there's a spike of dopamine rush, and then it starts falling off. And the same sort of thing with cocaine, which is why you get a quick high and then it falls off. We're not going to go too much into that, but just to remind us about neurotransmitters and the brain reward system and addiction as a brain disease. And this is one of those brain scans where you can see in the healthy brain there's activity, the darker red there, but when a person's been using cocaine in this example and depleting their dopamine stores, you get less activity, and that affects the function of all of the brain systems. ASAM in 2011 provided a new definition of addiction as, and there's much more detail to this, but addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. So again, emphasizing the brain reward system where using drugs activates the dopamine system, and when you get dysfunction in these circuits, then that's where you see the typical characteristics of biological and medical problems and physical health problems, psychological and psychiatric difficulties, social problems like legal difficulties, money, family, relationships, all of those social and environmental impacts, and then certainly the spiritual manifestations of addiction, where it really looks at people's values and demoralization and so forth. Another aspect then of ASAM's definition is that people with addiction are pathologically pursuing reward of that reward system by using drugs, or relief from pain by using substances and other addictive behaviors. So we know in DSM-5 now, the latest edition of the Diagnostic and Statistical Manual, the addiction chapter is called Substance-Related and Addictive Disorders, with the one behavioral addiction that's currently recognized by the APA being gambling disorder, although there's future work being done on another addictive behavior, internet gaming disorder. So that may well come up in the future. But the point is that addiction is about brains, not just about behaviors. It certainly is about behaviors, but when we think in criminal justice, we're focused more on behaviors and criminal activity, legal recidivism, and so it's understandable that the public and criminal justice systems are focused on behavioral problems. But it's important, and we'll talk about the implications of this, to recognize that it isn't just about behaviors. It's also about neurotransmitters and a brain disorder, which has implications for to what degree we hold people accountable for those behaviors. Holding them accountable for their behaviors for sure, but then how do we address that if we think they have the disease of addiction? This is the current edition of the ASAM Criteria, a 465 hardcover book, and we'll give you some information later on how you can learn more about that. What we're trying to do with the ASAM Criteria is really to move the whole treatment field and everybody involved as important stakeholders in people who have addiction. And that, of course, is criminal justice, child protective services, employers, family members, the public, helping everybody to understand addiction treatment as really being an individualized, clinically and outcomes-driven process, where we're moving away from placing people into programs, especially for fixed lengths of stay, which has been the tradition often in addiction treatment and is often the tradition in criminal justice, where we place people into a program for a fixed amount of time, thinking that that will then result in a great outcome. And predominantly in many areas still, addiction treatment is thought of by the public and by criminal justice personnel and by even treatment providers as somebody going off to rehab and completing a program. And the ASAM criteria, right from its beginning, has really taken the approach of addiction as a chronic disease, potentially relapsing, which needs to have a continuum of care, and where treatment is based on an assessment of a person's biopsychosocial aspects, where somebody is looking then at what are the problems and priorities within this person in an individualized assessment approach, looking at this particular person's severity of illness and level of function, and then matching that to the right intensity of services. What modalities does a person need in their treatment plan? And by modalities, we're talking about different strategies from different schools of thought. So cognitive behavioral modalities, medication modalities, individual therapy treatment, group therapy, family treatment, DBT, MET, all of these evidence-based practices that you hear about. What are we going to do for a person in their treatment plan? And then what level of service can we safely provide that level of treatment? And then to track their outcome and progress, are they getting better? What's their new severity of illness and level of function? If they're not getting better, what do we assess is the problem and how do we change the treatment plan? If they are getting better and they're making good progress and a good outcome, what do we assess needs to be done next in the treatment plan to help move them through chronic disease management and through to recovery? So this individualized treatment approach is what you should be expecting to see in state-of-the-art addiction treatment, and what criminal justice and court personnel should be expecting of people, not to plug a person into a program, but to expecting them to do individualized treatment based on a look at these 6 assessment dimensions. And these 6 dimensions are what drive the ASAM criteria process, and that define the kinds of severities and functioning that best are treated in what level of care. So very quickly, the first dimension, acute intoxication and or withdrawal potential, has to do with to what degree does this person need withdrawal management services. And we don't have time now to go into it, but actually this is an important dimension across all aspects of healthcare, because emergency rooms should be thinking about this dimension. Surgeons should be thinking about it. Mental health people should be thinking about this. When we see somebody on the street acting strangely, we should be thinking first, could this be acute intoxication? Is this a person who may be impaired and that's why they're driving recklessly or erratically? So actually, all people should be trying to think about, is this contributing to this behavior problem that we're seeing? But in a clinical treatment sense, dimension 1 is about looking at what does this person need in terms of withdrawal management? What does this person need in dimension 2 around physical health services? So diabetes, hypertension, asthma, HIV. What does the person need in dimension 3 around mental health services? Do they have mood swings because they have an actual co-occurring addiction and bipolar disorder, or are they having mood swings because they're using uppers and downers? So dimension 1, withdrawal management services. Dimension 2, physical health services. Dimension 3, mental health services. Dimension 4, motivational enhancement services, because we know from stages of change work that not everybody is ready to embrace recovery from day one, and that treatment may need to be education, risk advice, and attracting people into a change process. It would be wonderful if we could mandate everybody to be perfectly abstinent, perfectly non-psychotic, perfectly non-anger, perfectly, drug-free. But the fact is that if a person has the disease of addiction, it's an essential part of that illness to often have ambivalence about whether you even have the illness and whether you're ready to make the changes necessary to get a good outcome. Dimension 5 is looking at relapse prevention services, although you can't have a relapse unless you first thought you had a problem, wanted to stop, did stop, got into recovery from which you relapsed. So many of the people that we send to treatment from a criminal justice situation are not really even ready for relapse prevention services from day one, because they may not even think they have a problem of addiction to even be concerned about relapse. Of course, they think they have a problem. They think they have a judge problem or a probation officer problem or a spouse problem, but they don't think they have an addiction problem. So in that case, we have to work with them first on how you're going to not continue to use so that you get arrested again, how you're going to deal with continued problems of psychosis or mood swings or depression or suicidality so that it doesn't blow up. So this is an important dimension in making sure we keep people safe and also help them to, once they are in recovery, prevent relapse. And then dimension 6 is looking at where do they live, who do they live with, what are their friends and family, what are their legal problems, money problems, transportation, childcare. So you can see that this is a holistic assessment because it's important to identify these needs. Now, very quickly, when we're aware of the criminogenic factors, there is an overlap between what we look at in terms of antisocial values. This can have implications for dimension 3, mental health issues. It can have implications for readiness to change and attitudes about changing. It can have implications for dimension 6. Who are the friends? Who are they hanging out with? What are their cultural values? And the same with criminal deviant peer associations. That would be recovery environment. Substance abuse would be involved with intoxication withdrawal and can be involved in other dimensions as well. And then, of course, the family relationships clearly is related to dimension 6. We're sort of seeing the crosswalk there between criminogenic factors and what we should be assessing in state-of-the-art multidimensional assessment. And then once we've done an assessment, we have to plan treatment. And a good treatment program is going to want to be able to deal with motivational issues, stages of change. Are they skilled at motivational interviewing? Are they skilled at doing stage determined interventions? If somebody's at an early stage of readiness to change and doesn't think they have a problem, how are we going to do a different treatment plan for that person from somebody who is absolutely sure they have a problem and never wants this to happen again? It involves care management, looking at the needs in all 6 dimensions. It may involve medication for dimension 1 for withdrawal, or what you often think of as detox, but in the new edition of the criteria, we refer to withdrawal management, because we need to manage people's withdrawal, not just make sure they don't die from a withdrawal seizure. We may need medication for their physical health problems, diabetes, asthma, hypertension, for their mental health problems, psychotropic medication, antidepressants, antipsychotics, antimanic medication. And we may need medication-assisted treatment for relapse issues in addiction treatment. So that, again, remembering that addiction is a brain disease, that if we have medications that can affect those neurotransmitters, we can do a lot to help people with craving, with relapse prevention, to help people with withdrawal as well. And medications then are not an issue of philosophy, they're an issue of treating the bio aspects of this brain disease, if necessary. Not everybody needs medication, but if necessary to get a good outcome, we shouldn't be excluding that because of some philosophical issue. Meetings, I'm talking about self-help, mutual help meetings for dimension 2 for people's diabetes support groups, their cancer survivor group, for dimension 3 for their Dual Recovery Anonymous, Double Trouble in recovery, what we're trying to do with Emotions Anonymous, Schizophrenia Anonymous for their mental health issues. And then when we think about dimensions 4, 5, and 6, we're trying to help a person, if we send them to AA or NA or Smart Recovery, develop that support system that will provide them with ready access to people who can nurture them through recovery. And then we have to monitor all this because severity changes in these dimensions. Not everybody walks lockstep through a change process, so that we can change the treatment plan based on the outcome and the progress. Then we have to do this somewhere. So a good treatment program is going to not have just one level of care. They're going to have a continuum of care. And these are the broad levels within the ASAM criteria: outpatient treatment, intensive outpatient and partial hospital, the residential and inpatient levels, and then the most intensive and expensive hospital type level of care, medically managed intensive inpatient treatment. And this is just to emphasize again that if we think of addiction as a chronic brain disease that needs a continuum of care, that when we send somebody for treatment, and if a court is gracious enough to give a person a chance at treatment, believing that treatment of their addiction may in fact reach the goals we all want of increased public safety and decreased legal recidivism and crime, that we think this person is performing illegal behaviors because of an addiction illness, well, then we have to give them a chance at treatment, and to recognize that the ASAM criteria talks not just about one level of care, residential, but a whole range of levels. And I'm going to very quickly breeze through these to give you a sense about what the levels are, because you often think of, or the public often thinks of treatment as going off to rehab for 28 days or 3 months or 6 months. And they think of that as going off to a residential program. But really, state-of-the-art addiction treatment is really focused on a whole continuum of care. Early intervention, 0.5, is for people who do not have yet the disease of addiction. So this would be somebody who gets their first DUI, impaired driving. They may be arrested for an adolescent minor in possession, something drug-related, but not necessarily because they have the disease of addiction. They're going to need early intervention services like education, risk advice, and the hope of making sure they don't move into an addiction illness. For people who have opioid use disorder, we have a whole section on opioid treatment services where we talk about the importance of methadone, antagonist medication like naltrexone, which you may know of as injectable extended release naltrexone, the trade name Withdrawal, and buprenorphine, which is an agonist medication that does the same sort of thing as the neurotransmitters, and buprenorphine combined with naloxone, you may know as the trade name Suboxone. That's just one of the medications in addiction treatment. There, of course, are medications for alcohol use disorder and for nicotine use disorder as well. Very quickly, just to make you aware that for detoxification, that we call now withdrawal management in the new edition, there are 5 levels of withdrawal management, from ambulatory levels to residential levels to more medically and nursing care levels. So that when we think about detox or withdrawal management, which is what we want to be naming it now, we are really talking about a continuum of care and not just putting someone to a hospital for 3 days and then discharging them, wondering why they use again within a week, because we haven't actually managed their withdrawal. We just made sure they didn't die from a withdrawal seizure. But that's not managing withdrawal. That's just making sure they don't die from withdrawal. In the level of care for outpatient treatment, we have level 1, which is less than 9 hours of service a week for adults and less than 6 hours of service a week for adolescents. And of course, there's much more detail on this in the actual ASAM criteria book. The level 2s are 2.1, intensive outpatient, which is 9 hours or more for adults or 6 hours or more for adolescents, and 2.5, partial hospital, which is 20 hours of service a week or more for adults and for adolescents. The residential levels are made up of 3.1, which is clinically managed low-intensity treatment, meaning 24-hour living support, where a person may not need 24-hour treatment because they're not in imminent danger like in the other level 3s, but where you don't want them living back on the street, you don't want them being with negative influence in terms of their recovery environment, where they may not have enough skills to manage cravings to use, but they don't need 24-hour treatment. So this is 24-hour living support, which is often overlapped with some intensity of clinical services. This is a special level, 3.3, which has to do with people with cognitive difficulties, traumatic brain injury. They may have specific needs for a slower pace of treatment, a more individualized treatment because they can't cognitively address all of the issues. So this is a very specific population of residential treatment, but they're still in some imminent danger. That's why they need to be in a 24-hour treatment setting. Residential treatment 3.5 is, again, 24-hour treatment, meaning by ASAM criteria that if you're there, you are in some imminent danger that if you're not getting 24-hour treatment. So if you put somebody who a residential program and then they go to a pass to the mall, or you give them a pass to go home for a day, by ASAM criteria, that would not be residential treatment. That would be more like a supportive living environment, perhaps 3.1, with some intensity of clinical services. When we're talking about residential treatment in the ASAM criteria, we're really talking about people who, if they're not there, have very impulsivity around drinking and drugging or using or hurting themselves. They may have great difficulty in controlling impulses, and that if they're not in a 24-hour setting, they could be some public danger. So this is a necessary level, but people normally by ASAM criteria wouldn't be there for weeks and months and even a year. That would be more some living support plus clinical services. If they have medical issues, they may need 24-hour nursing with a doctor available to see them as necessary. And if they're very unstable physically and mentally and psychiatrically, they may need a hospital level of care with 24-hour nurses and doctors available whenever needed. So that is a very quick overview of the levels of care, and I wouldn't expect you to remember all those, but I do want to emphasize the point that when we're thinking about state-of-the-art addiction treatment by ASAM criteria, we're not thinking about one level of care for one fixed length of stay. And when we're talking about criminal justice populations, this is where we run into some difficulty because we are often used to mandating somebody to a level of care and a particular length of stay, when really what we want to mandate somebody to is assessment and treatment adherence. In other words, what level of care you go into and how long you stay in that level of care and how you move through the continuum of care depends on your own individualized assessment and how you're doing in terms of outcome. Are you really developing the kinds of skills that a treatment provider can say to the court team personnel, this person is changing such that we believe that they are incorporating the skills and the lasting change process that is going to increase public safety and decrease legal recidivism and crime and safety for children and families. If a state-of-the-art treatment provider can't give you the information that is helping you to understand that their client is actually changing, then those are the hard questions we want to ask of treatment providers. And in reverse, treatment providers have to be asking the court to please mandate assessment and treatment adherence, not a particular level of care and a particular length of stay, because how long this person stays in this level of care depends on their needs and their progress and whether they're actually changing to reach the outcomes that we all want. Let me pause here and see, Caroline, if there's any questions or things that need to be clarified before I go on to the next section of bringing this all together.
No, there are no questions so far, but please, everyone, feel free to send your questions in, and then we can send them to Dr. Mee-Lee.
Good. And again, if it's not specifically on exactly what I've said, please raise any questions. My goal here is to help you to get a sense about what good treatment should be and how do we start opening up the conversation between each other about that. Now, to try to pull this together, it then starts off with what does the client want? And in the session that we're going to be doing on Monday, March 14, we're going to be talking about doing treatment or doing time, moving beyond program phases to real lasting change. Because what we're really trying to do in addiction treatment that is mandated for people who have addiction is to really make sure they actually change. And so it starts off with, what does the client want? Why is this important? Well, because we want to engage them in a self-change process. We want them to enter that treatment program, not because they are just, doing what somebody else wants them to do, but to help them to identify why they chose to enter the program. Now, many of them may say, well, I didn't choose the program, they may become. Well, actually, they did choose and give permission to enter the program, and they actually do want something, otherwise they wouldn't have gone. Now, what they may want is to get off probation or to complete a drug court or some other specialty court, or to get their children back, or to end up getting a job or housing or whatever. But the first step is really to engage that person around taking some responsibility for why they chose to go into treatment. And we'll go much more into this when we talk about stages of change, and when we talk about doing time, not doing treatment, not doing time. But I do want to make sure that under Dimension 4, readiness to change, we're really trying to look at what is that person at action for, and that may not be, and for many clients it isn't, being at action for abstinence or sobriety or for wellness or for recovery. That's all right. Instead of the addiction treatment, we take people where they're at, not where we think they should be at, and then move from that point to attract them into recovery. The next step we have to do then is to use the ASAM criteria dimensions to quickly run through and make sure that the client doesn't have any immediate needs, to make sure that they're safe, so that if, for example, somebody is just stopped using alcohol or some other drug that's going to send them into severe withdrawal, even to the point of seizures, well, then we would want to identify in Dimension 1, acute intoxication withdrawal, the fact that this is somebody who has an immediate need, that we have to make sure they actually get into some withdrawal management level to make sure they're safe. Or if they, on Dimension 3, emotional, behavioral, cognitive conditions and complications are suicidal, we would want to make sure that we took care of that. So wherever a person comes in, you may remember sometimes that people have been jailed and then they've been found hanging themselves or some sort of suicidal behavior, because they may have been jailed when they were intoxicated. And then once they sort of detox, as it were, in jail, start feeling shameful and depressed and even suicidal, that then something bad happens. We have to assess then these important dimensions to make sure there isn't some immediate need. Of course, on Dimension 2, the biomedical conditions and complications, if somebody has an acute problem with they can't breathe, and we've seen criminal justice situations where somebody died on their way to the jail because they had an immediate need in terms of physical health problems. So certainly in those first three dimensions, we're looking at imminent risk in terms of life-threatening problems. In the Dimensions 4, 5, and 6, we're looking at imminent needs in terms of readiness to change. If somebody doesn't think they have a problem, or if somebody hasn't got a clue about how not to use, is going to get themselves into a dangerous situation, or if somebody is living in an environment where they're going to freeze to death tonight, that would be an immediate need in terms of Dimension 6 recovery environment. So again, we use those 6 dimensions to run through and to look at what are the immediate needs. We want to make sure that they're safe enough. If there are immediate needs, of course, we take care of that. If there's not, we go back through the 6 dimensions to assess what we need to know to make sure that they first have a diagnosis. And I'm referencing the Diagnostic and Statistical Manual of the American Psychiatric Association here, but you could use ICD-10, International Classification of Diseases, to first work out, does this person have a diagnosis? So if somebody does not have a diagnosis of a substance use disorder, but has been arrested for driving drunk, they will need some kind of service, but that's where they would, in ASAM criteria, get an intervention, early intervention 0.5 service. That would be like your typical impaired driving classes for somebody who has a first-time arrest. Now, it could be that that person who's in that impaired driving class actually does have a substance use disorder, so that good state-of-the-art impaired driving providers should also be able to identify who does have a diagnosis. It isn't a matter of just complying and going through X number of sessions of education to meet the legal mandate that they have to have some classes. It's a good provider of impaired driving services is going to want to identify which of these people, even if it's just a first-time arrest, actually have the disease of addiction, for which then just having them complete an educational class does not address the real problem, which is why you see repeat offenders, first DUI, second DUI, third DUI, because they just went through the hoops of compliance with some legal mandate, but didn't actually get an intervention in the disease of addiction, something that we would never do for any other illness. If somebody came in with an asthma attack and had trouble breathing, we wouldn't just stabilize that and then send them on their way without making sure they have some ongoing help. And if you identify somebody with an addiction diagnosis in a mandated impaired driving class, and then we don't do anything to make sure that they get help for their disease of addiction, then guess what? They'll be back threatening the public safety, not to mention the problem that has for that person in not getting treatment for an illness that they have and that we should recognize. So diagnosis is an important part of the process to identify, does this person need just education and risk advice, or does this person need addiction treatment? And so if you mandate somebody to treatment, a good program should be verifying the diagnosis to make sure that this person actually needs addiction treatment. If you have somebody who's been arrested for a drug-related offense dealing drugs, and they're not using their inventory for their own addiction, they're just a business person, an entrepreneur gone bad, doing illegal things, that person doesn't need addiction treatment. They need a criminal justice consequence for breaking the law. But if that same person who's dealing drugs is also using the drugs because of their addiction, then that's fine. They need addiction treatment. But this is the importance of understanding, do they have a diagnosis? And then we go through the 6 dimensions to look at a multidimensional severity or level of function profile, trying to understand what are the priorities for this particular person. Because in the assessment, we're trying to look at, do they have dimension 1 problems, dimension 2, 3, 4, 5, and 6? Which of these dimensions are most severe? And I say level of function here because we're not just looking at pathology. A good state-of-the-art program should be looking at strengths, skills, and resources. How are they functioning well? What, when this person wasn't being arrested, when this person was not in trouble with the law, when this person was working and had good relationships, what was going well in their life in these 6 dimensions? Oh, they weren't using on dimension 1, and that was why they were working well. They were in dimension 6, recovery environment, living with very positive people and had good friends. That was why they weren't getting into trouble. Oh, this is a person who on dimension 2 was running marathons, and then their physical health was really looking out for their physical health. This was when they were functioning well. So we want to look at when have things gone well in these 6 dimensions, and a good treatment program will be looking not just at pathology in these areas, but what are their strengths, skills, and resources. And then the focus then is to, once we've looked at those 6 dimensions, to assess what are their treatment priorities, because within each of those dimensions where there is a higher severity, we want to know what specifically are we going to work on in their treatment plan. Are we going to work on depression? Are we going to work on cravings to use? Are we going to work on the fact that they don't even think they have an addiction problem? Are we going to work on dimension 6, the fact that they have friends who all drink and drug and who are all involved in criminal activities? We're going to look at, on dimension 3, emotional, behavioral, cognitive, the fact that they have bipolar disorder or trauma. So we're going to identify in each dimension where there is some severity what the focus and target is, so that we can then make sure that the treatment provider will provide the right services for that problem, and that they provide the right dose and intensity of those services. Not everybody needs the same services for depression or for cravings to use or for difficulty with anger. Some people will need specific services to do with that, and not everybody needs the same dose of that, just as it is in dimension 1, acute intoxication withdrawal. If somebody has a withdrawal problem that needs detoxification and withdrawal management services, if their withdrawal is very severe, they're going to need a big dose of withdrawal management services, doctors, nurses, IVs, and all that. Or it may be that they just need a small dose where they could quite safely get that as an outpatient, because that leads then to the next aspect of where can these services be provided in the least intensive but safe level of care. Now, we say least intensive because we want to be good stewards of resources. There's only limited amount of money. And we want to make sure that we don't put a person into a more intensive and expensive level of care than they need. That's wasteful of resources. And what can often happen is that the person then is in a level that is more intensive than they need, and they disrupt the treatment milieu. They end up just leveling off and being passive and just sitting there and not really being challenged. We don't want to put them in a less intensive, unsafe level of care than they need, because then they get sicker or they get more impulsive. We want them to be in the right level of care, and this is what we do across all of healthcare. Not everybody starts their treatment for depression or diabetes or bipolar disorder or schizophrenia in an inpatient level of care. We want to start them at whatever level of care they need and then move them through. And as they progress in treatment, we want to look at what is their outcome. Are they progressing because they're doing well? And then what level of care could they be in? Are they not progressing well and they're just sitting there and not really changing? And what do we have to do then to really review and go back through the process? So pulling that all together, if somebody is not doing well, we want to go back and say, did we miss a diagnosis? Did we miss their trauma, their PTSD that's going along with their addiction? Or do they not even have an addiction diagnosis? And so we have them in the wrong level of care. They should be getting early intervention services. Or they may not be progressing and doing well because their severity of their dimensions has changed. Something has gotten worse, or something we missed when we went through. So this is why these feedback loops are here, to say, let's go back through what's going wrong to identify, has something changed in one of the dimensions? Now, we've been working on relapse prevention on dimension 5, when actually dimension 4 needed to be dealt with, because they don't even think they have a severe problem. And then, are they not doing well because we need to change the focus of what we're working on? Or we're working on the right focus and target, but the services need to be tweaked. Or we have the right services, but we don't have the right dose of those services. And that's going to impact what level of care we put a person into. So this is a dynamic process, not where somebody comes into a program and graduates at a certain amount of time as if everybody walks lockstep through a change process. That's not how change happens. That's not how we're going to get the outcomes that we want in terms of increased public safety and decreased legal recidivism and crime and safety for children and families. It has to be an individualized, outcomes-driven, assessment-based process where the treatment is changing all of the time. So what court personnel should expect from treatment providers is a clear articulation about what our assessment has found as being an important priority to go into. And, the court doesn't have to necessarily know every specific gory detail. You have to take into account confidentiality, but the court should expect to hear not just somebody is in a program and showing up, but are they actually changing, and are the outcomes actually moving in a direction that we can expect them to have better behavior in the public and to have better behavior in terms of criminal activity. And if the treatment provider can't articulate what they're working on in an individualized treatment plan, or more importantly, if the client can't articulate what they're working on in an individualized treatment plan, then something's gone wrong in terms of individualized treatment. If the client just says, I just have to be in this program, then they're just drifting through a program. They're not actually in a treatment change process. And what treatment providers can hopefully expect from court personnel is the mandate to do a good assessment, and then to engage that client in a change process that's going to be sustainable. And so that's why it's important not to mandate a particular level of care and a particular length of stay, because it depends on progress and outcome, not depending on just doing a treatment program. Right, let me pause there again and see if there's any questions. I don't know if people are not sure how to do that. You just type into the Q&A area there, and we want to make sure that we're keeping up to date with any questions you have.
No, we have quite a few questions, David, and I just want to say one of the common themes is that can people get the PowerPoint? Yes, we're going to send the PowerPoint and the link for the archived webinar. So here's a couple of questions that I think are really on point, because we find this in our technical assistance very, very frequent. First, can you provide some examples of substantive information evidence that treatment programs can provide to the courts, their justice partners, to demonstrate that a client is moving toward lasting change?
Yes, so if we go back to the 6 dimensions, you would want to be able to hear from treatment providers what is changing in each of these areas. So say, for example, they say when Joe came in for treatment, he didn't have any withdrawal problems because he was incarcerated just before he came. He was pretty healthy physically, so we weren't too worried about that. We were concerned about his emotional behavioral issues because he's had a number of angry outbursts, and he does have a history of having been in a psychiatric hospital. And so we're evaluating this further. We haven't seen yet any outbursts that make us worried, but we are looking at, once he gets a little clearer, perhaps getting a psychiatric evaluation, because there's a history of trauma and some outbursts. In terms of readiness to change, he's basically here to get through drug court and is ambivalent about whether he really has a problem, whether he wants to change his friends. That's why we're working on a motivational plan with him, and he is starting to make some movement, seeing that he may be, in fact, have more of a problem than he thinks. And then in terms of Dimension 5, he doesn't really have a clue about how he just thinks, I'm going to stop, and yet he's said that many times and hasn't been able to. And on Dimension 6, he still has a lot of friends who we want to work on helping him once he sees the importance of this, that he needs to look at changing in terms of his friends. In other words, a treatment provider should be able to say more than he's just here attending groups, and be able to give you a rundown of what's working and what's not working and what direction things are changing or not.
Thank you. And one of the things that we find in many of our site visits is that often the client does not have a copy of the treatment plan, nor does the court. Is that something that's important for them to have, David?
The treatment plan, the person who should know the treatment plan best is the client. The counselor has many clients in their caseload. it could be understandable. They might have to look at the chart. But if a person is in group and the counselor says, let's go around and each of you tell me what you want to get out of group to advance your treatment plan, and the client looks at you blankly and says, I just have to be here, they're not doing treatment. And we'll talk some more in later webinars on what a good treatment plan would be. But the bottom line is that the client should know their treatment plan. This is what I'm working on. I don't even think I have a problem, or I think maybe I have a problem. I'm working on gathering the data to prove that I either don't have a problem or to prove that I do have a problem. I'm ambivalent about giving up these friends, but I can see how maybe they get me into trouble. So I'm looking at how hard would it be to give up friends. I'm looking at these cravings to use. I'm still getting cravings to use. I'm not sure what. In other words, they should know what they're working on and what should be the strategies that they're trying to do. And so, yes, the client should have a copy of their treatment plan and know how to do it. So if a judge or court personnel says, tell me about your treatment plan, that would be a good question to ask a client. If they say, well, I'm just in the program, something's gone wrong. If you say, what are you working on in your treatment plan? If they say something generic like, well, I'm just learning about my disease or gaining insight, that tells you something about the quality of the addiction treatment. If you say, tell me about your treatment, what's the thing that you're working on most now? And they say, well, I'm not even sure I have an anger problem, but I'm getting into trouble with anger management. And in my treatment plan, I've got a role play with somebody next group. And because I don't think I have an anger problem, I'm going to show the group how to handle that without getting into a fist fight. Then you know you're getting some more specific kind of treatment. So whether the court has to have a full copy of the treatment plan, that's something that can be worked out between the client and the provider and the court as to how much detail you want. But what the court should know is that real treatment's happening, and you can tell that by to what degree the client and the treatment provider can talk about the treatment plan in an individualized way.
Thank you. And I know time is short, but there's two questions I think that are very apropos. One of them from Curtis Tyndall, actually both of them from Curtis, is it was my understanding that the individual had to have a high level of criminogenic score to be in the wellness court, and that does not sound like it's taking the participants where they are at. And I think this kind of is a broader question about, the focus is on high-risk, high-need participants. Is there some indicator that you would suggest indicates high-risk, high-need, or is it taking all these dimensions together and seeing how they're moving as the person progresses?
Yeah, so when we talk about high-risk, high-need and focusing resources into that population for drug courts, that's an example of trying to be efficient with resources and to focus resources on the highest need people. So when we talk about high risk, high need, we're talking about high risk, high need in terms of legal recidivism. So criminogenic factors, my understanding is, has to do with high risk, high need in terms of likelihood to reoffend. And there is some overlap, as I pointed out. So when we're thinking about criminal justice and addiction treatment, it may be the ones that we put the most intensive resources into, being the high risk, high need in terms of the risk for legal recidivism. But what I would also say, though, that if you have a person with addiction, say you have a person in addiction who doesn't have all these criminogenic factors but has been arrested for a DUI, it would make sense to make sure that person gets some addiction treatment, not necessarily residential treatment, because they then recidivate and end up getting another DUI, as we see so often. So my argument would be, if somebody actually has the disease of addiction that we think results in criminal behavior or offending, we need to give them some sort of treatment. We may reserve our most intensive resources for the high-risk, high-need people that we can identify in terms of legal recidivism. That's where criminogenic factors come in. But we need the continuum of care, I think, for anybody who has an addiction problem who we think that causes legal problems. if we think treatment of that will then result in decreased legal recidivism.
Thank you. And one of the things that we're encouraging is to have multiple tracks in drug courts so that it can be individualized in terms of the resources that are needed. So here's another question from Curtis, which is related, another common question. We have a 5-phase system for our program that each client goes through doing all the same requirements. But what I'm hearing is that individually a client may not need all 5 phases or may skip phases. So one client may use the entire 10 months and another 6, which is, I'm so glad you raised this question because that's something we hear all the time. Could you comment on that, Dr. Mee-Lee?
Yes, and we're going to go into more detail on this in the March webinar as well. But if you're going to have the phases be linked to functional improvement, not to jumping through hoops or time. So you may want to have phases as a way to know where is this person at, but to use those phases so that a person can move from one phase to the next or even skip phases if their function has already been achieved. It's a bit like, if you're testing out of a course, they give you, an exam first, and if you test out that you don't need some of the classes, you don't get those classes. And in a similar way, if your phases are describing levels of function, then it may be that somebody comes into a situation further along than somebody else, or somebody's progress through those phases is not as fast or maybe faster. So in general, phases can be used correctly if they're linked to function, but if they're linked to just time and jumping through certain hoops of going to certain numbers of meetings and so forth, or certain drug screens and whatnot, then you'd have to look at whether the phases are actually encouraging people to think of this as just going through phases rather than focusing on accountable real change. So there's a way to use phases in a way that can be individualized, and there's a way to use phases that are counter to real sustainable change. And we're going to address some of that in the next webinar.
Yes, I know that you're going to address this in the next session. We have one more, and then we have other questions, but we will address these tomorrow as well as anything else that people submit. Lars Levy asked, does Dr. Mee-Lee have any suggestions of functional multidimensional assessment and or risk needs screens that you could recommend?
Well, when you think about each of those 6 dimensions, there are all sorts of instruments within those dimensions, standardized instruments that can help you look at readiness to change, look at craving scales, can look at mental health stability, can look at physical health stability. So depending, for research studies, people get very detailed about that. But you don't necessarily have to have a lot of standardized instruments, even though they exist for Dimension 1 for withdrawal, severity, and each of those dimensions have scales that you can do. But even if you just look at it from a clinical point of view, a good treatment provider should be able to tell you whether things are changing in that. But there are there are a whole variety of standardized measures for each of those 6 dimensions. I wanted to just point out a couple of resources, asamcriteria.org, if you want to know more about the ASAM criteria, and there are some e-training modules that you can also see at asamcriteria.org as well, so that you can have a chance to build knowledge on this if you wish. Caroline, we will, I hope, have more of these questions tomorrow. Do you have a bunch still left?
Yes, we have several that are still that have been submitted that I think will take some time to answer, and I thank everybody for sending them in, but please send more, and we will then reconvene tomorrow for those that you are free and have a chance to interact with Dr. Mee-Lee on some of these issues, as I know it's really bringing a whole change of paradigm to many of the programs. So we really appreciate so much, Dr. Mee-Lee, you're working with us. So I think
and again, people have to re-register, is that right, if they want to be tomorrow?
Right. Just re-register. If you have any questions, just send the email back, and we'll send it back to you, and then you'll be all set for tomorrow. Well, thank you, everyone, taking time to participate in this session, and we look forward to following up tomorrow. And thank you, Dr. Mee-Lee, for your time and all your insights and your patience in working with us.
Sure. Thank you.
Okay. Bye.
Bye-bye.